Welcome. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. Today, we'll learn about managing food impactions from Dr. Anthony Olive. Dr. Olive is a pediatric gastroenterologist at Texas Children's, where he is the co-director of the Eosinophilic Gastrointestinal Diseases Clinic. Welcome, Dr. Olive.
Thank you, Jennifer.
You're welcome.
And welcome to everybody. Let me share my screen here. Welcome everybody, and good afternoon or good morning, depending on where you are located. As Jennifer mentioned, my name is Dr. Anthony Olive, and I am Associate Professor of Pediatrics in the section of Gastroenterology at Baylor College of Medicine and Texas Children's. And today we are going to discuss the management of food impactions in eosinophilic esophagitis. So we'll go through a little background on EOE, which may be redundant for many of you guys, but nonetheless, we'll go through the definition, give you an overview of EOE, how we diagnose and evaluate it, and then ultimately finish up with what we're charged with today, which is to discuss food impaction management. So EOE is a chronic immune mediated, so chronic meaning that it relapses. If you find a treatment that works and you stop that treatment, it tends to come back. The immune system is responsible for the inflammatory process. So it's the immune system responding to certain food or aeroallergens that ultimately leads to the inflammation and to the clinical symptoms of esophageal dysfunction and histologically an eosinophil predominant inflammation. So in other words, you have to have clinical symptoms, but you also have to have the inflammatory response with the eosinophils. So EOE is a relatively new kid on the block as the history of time goes. Some of the early reports came out a little less than 30 years ago in Baltimore and then in Switzerland, but a couple decades later, it was all over the map. So it's a condition that is being more and more recognized throughout the world and by providers throughout the world. So if you look at the prevalence of EOE, it really hasn't changed a whole lot since this report by Dellon et al. In 2013. Roughly about 50 to 60 per 100,000 people have EOE. We've known for a long time that males are much more likely to have EOE, up to a 3-to-1 ratio. But the general prevalence has stayed roughly the same, possibly a little bit of an uptick. In this most recent report, again, kind of a follow-up by Dellon, anywhere from 50 to 100 per 100,000. There was a report from in a fairly homogeneous population in Sweden, where adults seem to have a higher prevalence than children did in that particular population. So again, males have a higher prevalence for EOE. Really, if you look at the peak, 4th and 5th decades, but really anybody at any age, including children, which I deal with, can get EOE. Individuals with EOE are highly atopic. So if you look at the prevalence of atopic conditions such as asthma, allergic rhinitis, and atopic dermatitis in the general population, it's much lower than in EOE, as evidenced by these 4 subsequent reports where prevalence of atopic conditions can be upwards of 50%, and much higher than what one would see in the general population. Prevalence of food allergy is also much higher in EOE compared to the general population as well. So really all atopic conditions are much more common in patients with EOE. So in summary, the sort of prototypical EOE patient is an atopic male, presents either in childhood or in the 4th or 5th decade of life. Again, as I mentioned, but really at any age. And we see the patient present with EOE, and it's predominantly in non-Hispanic whites as well. So, the inflammation really comes, there are several genes that have been identified that predispose or sort of risk genes to getting EOE, and these genes have primarily to do with barrier function and the inflammatory cascade. And so you get an antigen that comes in, and then in a genetically susceptible individual, you have this inflammatory cascade that follows, that ultimately leads to inflammation and some of these endoscopic findings that we see, and with long-term inflammation that goes untreated, ultimately the development of scarring and fibrosis and strictures in the esophagus. So again, the natural history is early on. There's an inflammatory process, but again, over time, onset of scarring can set in and cause even more problems and more risk for esophageal food impactions, which we'll get into in a bit. So the diagnostic criteria, as I sort of alluded to earlier, you have to have esophageal dysfunction symptoms. And we'll see in a minute that can be quite variable, particularly in the pediatric age range. Those symptoms can be. The concomitant atopic conditions are often present. And then endoscopically, which I'll show you pictures of here in a second, we can see rings or furrows, white exudates, edema, and then with more advanced disease, stricturing and total narrow esophagus. Histologically, we use the cutoff of 15 eosinophils per high power field, although we certainly have diagnosed individuals with EOE that had less than that if everything else fit. And we've certainly had individuals with more than 15 eosinophils per high power field that did not get diagnosed with EOE and instead had reflux, acid reflux, because there can be some overlap because the rest of the picture didn't really fit. But, that's the general kind of guideline. And it's important to assess for other conditions that can cause esophageal eosinophilia that could be contributing to the picture. And here's a list of some of the more common ones besides acid reflux, which I just alluded to. Other eosinophilic gastrointestinal disorders beyond the esophagus that can also have some esophageal eosinophilia: celiac disease, Crohn's disease, different infections, drug hypersensitivities, achalasia, which is a motility problem of the esophagus where food can be stagnant in the esophagus and cause reactive eosinophilia. Connective tissue disorders, graft versus host disease, where like bone marrow transplants, where the actual transplant attacks a part of the host, etc. And so, as I mentioned earlier, the clinical presentation, particularly in the pediatric age group, can be quite variable depending on the age group. So early on, infants and toddlers tend to present with feeding disorders. They just don't eat right. They have food aversions, et cetera. Maybe some vomiting. Whereas older individuals may have the more, so teenagers, preteens, teenagers may present with the more classic adult type symptoms of dysphagia, swallowing difficulty, or they actually can report the swallowing difficulty to you in food impactions. This is just another more recent publication from this year, again, highlighting that there can be differences in the presentation depending on the age of presentation in the pediatric age group with EoE. In the adult world, EoE has become a much more prominent, more recognized cause of dysphagia between 1999 and 2009, more so even now, as EoE becomes more recognized among providers and patients alike. Some of the screening questions you can ask, because again, particularly in pediatrics, which is my world, the kids don't always tell you. So things like, does it take longer for your child to eat? Do you need to cut the food up in small pieces? Do you always have to drink after meals? Do you eat steak? Do you avoid steak? Things of that sort. Just kind of little questions that can give you subtle pieces of information that might suggest that there is some esophageal dysfunction going on. So the evaluation, the gold standard for evaluation in 2024 is still endoscopy with biopsy. The data suggests that a total of 6 biopsies approximate 100% yield. My practice is to get 4 biopsies in the proximal and 4 biopsies in the distal esophagus, but that practice can vary from individual to individual. And then you should always, at least on the initial endoscopy, you should get stomach and duodenal biopsies to exclude non-EoE eosinophilic gastrointestinal disorders. And so, and then it's again the endoscopic features, which will go into can be suggestive, but really it's the biopsies that are the gold standard in 2024. And then X-rays sometimes can be useful depending on the symptoms the patient presents with. If there have been some food impactions before, it's probably wise to get a barium study to rule out a stricture or total narrow esophagus before one goes in with the endoscope, to have that information ahead of time. So picture A is normal. You see the vascular markings, and then on B, we see the linear furrows that are pretty classic for EoE. C shows the white exudates that represent eosinophilic microabscesses. And then D is the rings which represent, in this case, non-obstructing rings, which represent early fibrosis. And then E, you can see there's more of a narrowed esophagus, and the endoscope has created this this esophageal tear or rent, which can happen when you try to go through a narrow esophagus. Okay, so why do we treat? It's really twofold. One is to help symptoms, but the other is to prevent the complications of esophageal fibrosis and stricture formation. Again, this just highlights that the longer you go with untreated inflammation, the more at risk you are for developing fibrosis. Okay, so that's kind of an overview. I hope that wasn't too redundant for you guys, but we'll now get into esophageal food impaction management. So this is the endoscope. The endoscope's the equipment that we use, which I'm sure you guys have all seen. And these are some of the devices that we can pass through the endoscope to grab the food impaction. There's nets that can be used, snares, and then graspers. And then we can also use these fit adapters, which are used for esophageal varices, where you suction so varices are like varicose veins in the esophagus that people with liver disease can get, and they're used to suction the vessel into the device, and then these you see the blue rubber bands are deployed, and they sort of ligate the bands. Well, you can use the same equipment to sort of suction food into them and then take it out piece by piece, and they can be fairly effective. And then this is a picture of a using a Roth net to grab a food bolus and extract it from the esophagus. So some of the concepts that we'll discuss, some of the more important concepts with esophageal food impaction management are: what do we do about patients who have non-endoscopic resolution of their esophageal food impaction? So in other words, they come into the ER, they've had a food bolus stuck, but then during the course of the ER visit, before any intervention can happen, the food bolus passes, it self-resolves. So what do we do with those patients? How can we assess the risk of somebody having an esophageal food impaction? What's the role of imaging with esophageal food impactions? And what's the timing? Is it important to address the impaction immediately? Can it wait, etc.? Push versus pull. So do we push the food bolus forward, or do we pull it out with those devices that I just showed you? What's the importance of taking biopsies? Is it important to take biopsies at the time of the esophageal food impaction? Is it important to dilate if there's a stricture present at the time of the food impaction? Is it important to dilate it at that time, or can we wait and do that later? And what are some of the potential alternate therapies besides endoscopic management? So this paper from 2023, recent paper, addressed the issue of non-endoscopic removal or resolution of esophageal food impaction. And so they looked at 593 patients, 149 or 25% of which had non-endoscopic resolution of the food impaction. And it turns out that those that had that were less likely to follow up than those that had endoscopic resolution. So in other words, there was some feeling that, or well, who knows, but perhaps the patients felt like, well, this happened to me. It went away on its own. I really don't need to have any follow-up. But it turns out that those that ultimately were endoscoped, over 90% of them had some significant esophageal pathology, whether it was EOE or gastroesophageal reflux stricture or esophageal cancer, or what have you. So again, what this highlights is that there really needs to be some sort of protocol set up where patients that do have this self-resolution do get followed up. So some efforts need to be made to assure follow-up in these patients. In terms of risk, this paper from 2022 looked at 291 EOE cases. These were in adults, and it was really furrows and rings, the presence of furrows and rings on the initial endoscopy that ultimately predicted the risk of esophageal food impaction in the future. Of note was that females were less likely to develop an esophageal food impaction. Also, interestingly, insurance and socioeconomics didn't seem to impact risk, which to me is counterintuitive, and it would be interesting if that finding could be replicated, because in lack of insurance would go along with with individuals who are less likely to seek medical care, and so it seems like those individuals would be at higher risk. But nonetheless, in this particular retrospective study, it didn't seem to make an impact. So imaging is one of those things that I think is very useful if you can get it done, because it's important to know where along the esophagus the bolus is. Number one, so you're prepared, but also to determine which is the correct specialist to take that out. So very, very high boluses might be better handled with the rigid scope that, for example, an ear, nose, and throat doctor would use. But it should not delay the endoscopic removal of a food bolus if the patient is in dire straits, if they can't handle secretions, if they're having any respiratory difficulties. So it's ideal, but not an absolute necessity, depending on the clinical situation. So in terms of timing of endoscopic management, this was just a survey of mostly European docs, trying to get a sense for what was the practice out there. This was from a couple of years ago in 2022. 41% of those surveyed said that the bolus should be removed within 1 to 2 hours. Interestingly, 43% recommended biopsy, but 77% of those who had a lot of experience with EOE recommended biopsy. So it was clear differences in practice patterns. And so their ultimate suggestion was that there should be some development of guidelines, more standardized guidelines in terms of timing of endoscopic removal. This was a paper from this year where 188 patients with esophageal food impaction were reviewed retrospectively. The 12% of them ended up with some kind of adverse event. Only 1% had serious adverse events related to the food bolus. Increased adverse effects risk was related to older age as well as underlying esophageal dysmotility. Interestingly, the time from esophageal food impaction to the endoscope was not associated with increased adverse effects in this particular study. Now, there are other studies out there that contradict that. So that is a controversial area, but generally speaking, timing is dictated by symptoms. If someone comes in with respiratory difficulty, unable to handle secretions, significant chest pain, the timing obviously is much more imperative. So then the question of push versus pull. Do we push the bolus through? Its traditional thought and education was that you should not really push a bolus through because it's risky. If there's a stricture below, you might create a perforation, etc. So this paper from 2023 really looked at a large number of endoscopies. This is again retrospective, just reviewed, and about half of them, interestingly, about half of the patients had the push technique, and the other half had the pull. But there was really no statistical significance in terms of the success rate of the push versus pull technique, as well as no difference in the adverse event rate between the two. So the conclusion really was that both are acceptable. So in terms of biopsies, do we biopsy or not at the time of food impaction? And so Hirameth et al. In 2018 surveyed 428 pediatric and adult GI doctors, and 34% of them biopsied at the time of esophageal food impaction. Interestingly, pediatric GI doctors were more likely to biopsy than adult GI doctors. And his group estimated that based on that low percentage of biopsies, that over 10,000 patients who would be at risk for EOE were missed each year. This paper from 2019 looked at 220 adults seen in the emergency room for food impaction. 74% of them were male. 70% of them were biopsied in this population. Interestingly, of those not biopsied, almost 80% of them were lost to follow-up. There was still a fair amount of those lost to follow-up, even if they were biopsied, but much less than those that were not biopsied. And so the idea here is that biopsy is important for a couple of reasons. One is, obviously, you don't want to miss something like EOE at the time. That might be your only chance to catch it. But secondly, there seems to be something about if a patient is biopsied, it sort of tells them that, hey, maybe I need to follow up, or makes them more likely to follow up. So potentially a way to get more patients to follow up. This was another paper, a smaller cohort of children with esophageal food impaction. 74% of those were diagnosed with EOE. And the only endoscopic feature that was associated with EOE in this group was the linear furrows. And so the idea here is that most kids with esophageal food impaction have EOE, or the majority of them do, and that biopsy should be done at the moment of the esophageal food impaction. So the next question is, what about dilation? Do we, in a patient who has a stricture or an esophageal narrowing at the time of food impaction, do we dilate or not? Some people don't, because the food bolus can cause a lot of inflammation, and there's concern that that inflammation, if you dilate, might increase your risk of perforation, et cetera. So this paper from 2020 looked at that issue. 102 adults who had disimpaction of their food impaction. 20 of those had an immediate dilation at the time. 82 were recommended for interval dilation, meaning that they did not have dilation at the time, but were told to come back in 3 months and begin a series of dilations at that time. And so of those 82, 38% of them did not return. And of those that did not have immediate dilation, 4 of those had an esophageal food impaction within 3 months before they could actually, before it was time for them to come for their initial dilation. And so their conclusion was, one of the conclusions was that if without a dilation at the time of, if it's indicated, if there's a stricture at the time of the esophageal food impaction, it increases your risk of having a recurrent food impaction. And so what about alternate therapies? So people have proposed using proteolytic enzymes, essentially food tenderizers, to sort of dissolve the food impaction. And this is not recommended. The erosions can happen in the esophagus, perforation. Some of these food tenderizers have very high sodium contents, and so one can get high sodium levels in the blood. Glucagon is another agent that has been used to sort of relax the smooth muscle around the esophagus. There have been some papers that have shown it to be efficacious, particularly in adults. There's not really any in kids that have shown it to be efficacious, but the findings have been sort of controversial. So the current recommendations really are that it's not worth it because of the potential side effects, particularly in kids, of nausea and vomiting, that we really don't recommend its use in most cases. These are a couple of just case reports of, this was a 34-year-old. The first one was a 34-year-old with EOE and came into the ER, was given some warm water, and action resolved. This were the second study, or the second report, was a couple of patients also had EOE, came in with steak impactions, were given some nitroglycerin orally with tap water, and their impactions, both of them in both cases, resolved within a couple of minutes. Again, these are just isolated reports. We know that esophageal food impactions can resolve spontaneously. So, isolated reports like this don't really tell you a lot outside of the context of what's really needed is sort of a controlled studies, placebo-controlled studies, where to see if there's any significant differences in one approach versus the other. This was from 2019. 239 patients were reviewed, and 45 of them were given an effervescent agent that releases carbon dioxide, and presumably the pressure from that sort of pushes the food bolus down. And interestingly, there was a 55% response rate in the same group. Those that were given glucagon had a similar response rate to those that were given no therapy. Again, those that got endoscopic removal had 100% success. Budesonide is a medication that we use to treat EOE, and so this is a report of 8 adults who came in who had EOE. 6 of the 8 had EOE. Came in with esophageal food impactions and were given the budesonide oral dispersible tablet, and 3 of the 8 had their food impaction resolved without endoscopy. Again, the question here is, were these going to self-resolve anyway, or did it have anything to do with the budesonide? So more studies really are needed to determine whether this is an effective alternate therapy. So in summary, EOE is a common cause of esophageal food impaction, particularly in children. Adults can have a lot more things that can cause food impactions, a lot more pathology. But if you see an esophageal food impaction in a child, you have to think EOE, unless they've had some clear history of other tracheoesophageal fistula or some other esophageal pathology. The timing of the removal really depends on the symptoms. Those that are really not doing well, obviously urgency is the urgency is there. Otherwise, it doesn't have to be immediate, but certainly should be removed within 12 to 24 hours. Imaging is ideal before going in with the endoscope, but not always practical depending on the symptoms. Establishing protocols for follow-up is key. Patients that don't follow up are likely to have misdiagnoses. Patients that don't follow up are likely to have recurrent esophageal food impactions. So improving our follow-up rate really is paramount. It's been shown in a recent publication out of Denver that something as simple as just a written request to follow up, giving the patient written instructions to follow up, makes a big difference in follow-up rates. Biopsy at the time of impaction, again, is important to not miss diagnoses. Dilation at the time of impaction may be useful. And then alternate therapies really need further study. So that's really all I have. And I think we'll hand it over to Jennifer at this point and any questions you guys may have.
Thank you so much for such a wonderful presentation. So many insightful studies, and it looks like lots of opportunities for further research.
That's right.
Well, let's go ahead and go through some of the questions. So if you're joining us live right now, please go ahead and open up that Q&A box and start typing in your questions. We'll use that to be able to get our conversation going. So the first question that came in is, what kind of imaging is done for food impaction? You've referenced that it can be helpful before going in with a scope. Is it an X-ray, a CT scan, something else?
Yes, that's a wonderful question. And so traditionally, barium studies have been used to sort of identify where the food bolus is, and they still are, but really more and more CT is sort of taking over that role. You can get very good definition of where the food bolus is with the CT, and it involves a little bit more radiation, but I think generally it might be a quicker process as well. And so that's kind of been the favored modality, lately.
Okay. People are also curious, is there any way to determine like if a specific food is causing the impaction?
Not really. It's just really history, right? What did you eat, right? Asking the patient what you ate. That's statistically, meats and breads are more likely to get stuck. But yeah, really obviously anything can get stuck, but meats and breads that are not chewed well is what we see the most of. So if you were just guessing, it would be that. But asking the patient what they ate is the best way to determine that. At the end of the day, I'm not sure it makes a huge difference. I mean, you're still going in to get it, but yeah, so that's.
Okay. So you talked a little bit at the beginning about some history and references about EOE itself. And so we got a general EOE question as well. Is there a way to determine what foods are causing someone's EOE?
That's a great question as well. And so, the way you do it, the way you determine that is what we like to do is there's no good, first of all, there's no good testing. So unlike with immediate allergies, IgE immediate allergies, where the skin prick testing and the serum specific IgEs can give you a sense, along with clinical history, can give you a sense for which foods are the causative agents. With EOE, there's not good testing. People have toyed around with patch testing, atopy patch testing, which is a more delayed type, and in certain hands, it may be useful, but it's not generalizable. And so it's very operator dependent. And so we tend not to use that. So the empiric elimination diets are really the best way to determine which foods are triggering the EOE. And so, and that's just basically using a diet that takes out the foods that are statistically most likely to cause EOE. Dairy, as you guys know, being the biggest culprit by far. And at our institution, we like to do a 4-food elimination diet, which takes out dairy, wheat, egg, and soy. And then the idea there is after a 3-month period of time, assuming the symptoms improve, we repeat an endoscope. And if things are clear, then we know that the culprit is in there. It's one or more of those foods, and then we systematically introduce one back at a time and try to sort out which is the causative food. So that's really the best way to determine that.
Thank you. So if someone experiences a food impaction, how do they know if it's been resolved, if they have not sought medical attention for it?
Yeah, another great question. So it's not always evident. So, I mean, in some cases, the symptoms just totally go away, right? You don't feel anything, but it is possible to still feel like something is there even after it's gone. Now, obviously, if a patient comes in, they're still not handling their secretions, and then there's something still there. But so in a patient that came in with those symptoms, if they all of a sudden were able to handle their secretions that and swallow their saliva and so on, that might be an indication. But it's not uncommon for the food bolus to pass and still feel something, depending on how long the food bolus has been there, because it can cause some inflammatory response. Just the presence of the food bolus could have the pressure could have caused that, and so there still may be some lingering symptoms. And so in that scenario, the X-ray, the CT or the barium study would give you that information.
Does that then, is there anything that you recommend to patients in terms of if you've experienced a food impaction, do you need to get one of those scans every time? What kind of advice would you have?
So yeah, so if you're coming in for an endoscopic procedure because you feel like you have a food impaction, I think it's a good idea to get an imaging study before the endoscopy is done. It's not an absolute necessity, but I think it does help to know where it is and also how extensive the food bolus is.
Okay.
So yeah, so I would now, if you're at home and you have the impaction, and then it come before you even leave, you feel like it's gone, you still feel a little something, but you feel better overall. Is it urgent to run into the ER and get an image? No. I think you can call your doctor in that scenario, and if it's after hours, even call them the next morning. If you're doing clinically okay, and see if there's anything that needs to be done at that point. But
Thank you. So if someone has a child who is experiencing a food impaction, what should the parent do and how can they prevent it? The person that's writing in here has a 5-year-old with EOE, and is looking for advice for how to help her child.
Well, the best way to prevent food impaction is to have your EOE adequately treated. That's number one. But assuming that, and then obviously the other way is to make sure your child chews their food well and that you cut their food up very well. If it's already happened, I think at that point you just have to go to the ER. If your child is experiencing any kind of discomfort in the chest after eating, and as a parent, you're going to know this. My child is there's something going on. This is not how they normally act. Obviously, if they're verbal, they can tell you more. But so yeah, I think unfortunately, you don't want to wait on that because too many complications can happen. They're at higher risk for perforation. May get some, if they're not handling their secretions right, they may get some aspiration pneumonia, maybe even some other breathing difficulties. So I think the better part of valor is to go ahead and go in if you have any suspicion at all.
How might a child describe a food impaction?
Yeah, so chest hurts, beating on their chest, I can't swallow. Those are the kinds of things that, pain in my back, my upper back, potentially, if the timing is right with eating and so on. So, those would be the things, if they're not verbal, it's a little harder, obviously, but then you'd have to rely on other signs such as drooling and things of that sort.
Okay, thank you. So we've got a question from the audience. Is there any value in inducing vomiting to remove a bolus?
So that's a great question, and I would not advocate for that, just because I think you run a higher risk of perforation If you induce vomiting, you increase pressure in an area where already there may already be some pressure. And then, you also run a higher risk of aspiration and so on. So I would shy away from that. I think most people would agree with that.
So you've talked about meat being a trigger. So people are curious, if meat gets stuck, is it considered an EOS trigger? Or is it just that the esophagus is inflamed from other foods and the meat happens to get stuck?
Yeah, the latter is the case. So, I mean, there are some people who have beef and chicken triggering their EOE, but that's the exception rather than the rule. So it's really more the mechanical nature of meats and breads and so on that they're just more likely to get stuck in an inflamed esophagus.
Okay. You talked before about symptoms that people might use to describe when they're having a food impaction. And a follow-up question that we have is when someone's trying to recognize if they're having a food impaction, will it impact their ability to swallow other food or water? Like, is that a sign? If you can't swallow food or water, then you're having a food impaction?
It certainly could be, yes. I mean, it could also be a sign of just active EOE or active esophageal inflammation. But yes, if you have a food impaction, you won't be able to swallow other food. You may be able to swallow water depending on the degree of the impaction. It might trickle around, but other food is not going to go through.
Okay. So if someone has a food impaction, at what point should they consider going to the emergency room? People are curious, like, how long do you wait for the food to shift before you go seek emergency support?
Yeah, another great question. I just think the better part of valor is to make your way towards the ER. If it happens to go to resolve on the way, great. But I think you're better off not waiting. Too many bad things can happen if you wait.
So we've got a question about pathology reports. So if you maintain remission from EOE on a pathology report, but continue to have worsening fibrosis, what can be done to prevent food impactions?
So if you've got ongoing fibrosis with significant symptoms like recurrent food impactions and esophageal dilation, apart from doing the things that you need to do with your food and chewing it and cutting it up and so on to prevent any impaction, you may be a candidate for a series of esophageal dilations to sort of widen the lumen of your esophagus and make it less likely that you get the food impaction.
Okay. You talked before about the 4-food elimination diet that your practice does, and we've got some follow-up questions about egg. They're curious how common egg is as a trigger for EOE. They said that their child has EOE and is allergic to eggs. And so they're curious about the overlap between triggers and food allergies.
Yeah, so egg statistically is pretty similar to wheat. So dairy is the biggest culprit, then wheat and egg kind of are tied for second, and then soy in terms of EOE. Now, if you have an IgE mediated egg allergy, that doesn't necessarily mean that the egg allergy is triggering your EOE as well. So it's pretty common for patients that have EOE to have food allergies I mentioned earlier. But that food allergy well, often it's hard to tell because, or I should say, we know that there's other triggers because, obviously if you have an egg allergy, you haven't had exposure to egg in a while, right? And so if you've got EOE, then there's other triggers, right? Egg could be a trigger, but you're eliminating it for other reasons anyway. So, but then the question is, okay, what happens when I outgrow my egg allergy? Is it going to trigger my EOE? And that's possible. It's possible, but it doesn't mean you shouldn't try. You shouldn't try to introduce egg. You know, I mean, it could be a trigger, but it may not be. So
Lots of variables.
yeah, lots of variables. Exactly.
Well, is there anything that we haven't asked you today about food impactions that you'd like to share?
No, I think I would. I think the biggest take home is that they are not to be taken lightly. You should seek medical attention sooner rather than later if you feel like you have one. If you feel like you're at risk for a food impaction, and we've been discussing food impactions more in the context of EOE, but there are other individuals, particularly adults, that have risk for food impactions for other causes. But if you feel like you're at risk for having a food impaction, speak with your gastroenterologist about, are you a candidate for some dilations to reduce your risk, but also be smart about the foods you eat, how you eat them, how well you chew them, etc.
Well, thank you so much. This is really helpful, and we appreciate all the time that you took to be able to answer everyone's questions. We just really appreciate your insights.
Of course, I'm happy to participate. And I do appreciate you giving me the opportunity.
We appreciate it. Well, we also want to thank our education partners for their support of this webinar series. And for today's webinar, that includes Bristol Myers Squibb, GSK, Sanofi, and Regeneron. Our next webinar will be on June 25th, and it will be about EGPA. And we're going to talk with Dr. Juanita Mora about tips for self-management. Registration for that webinar will open soon. You can also continue learning about more eosinophil-associated diseases by subscribing and listening to our podcast, Real Talk Eosinophilic Diseases. In the latest episode, our co-hosts Holly Nodowitz and Ryan Piansky had a conversation about spoon theory and how it can be applied to eosinophilic disorders. You can listen to it at apfed.org/podcast, as well as on many podcast tools such as Apple Podcasts, Spotify, and Audible. Another great opportunity is to attend our annual patient education conference. EOS Connection 2024 will be in the Washington, D.C. area. Please join us this July. Head on over to apfed.org/conference to register. You can either register to join us in DC or you can join us online. It's a hybrid conference, so you've got some options. Finally, we encourage you to continue the discussion started today in our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. You can check it out at apfed.org/connections. Thank you again for joining us today for APFED's EOS Support webinar series. If you have a question that didn't get answered today, please email mail@apfed.org. I hope everyone has a great afternoon.